Hi, I am Dr. Rahi Victory, your host, and welcome to Fertility Fact or Fiction. We have a show every week where we discuss things that are important for patients either pregnant or trying to get pregnant, and those who are suffering with infertility. And we answer all your questions live. So tonight's show, we talked about last week and came out of a post that I responded to online. And I thought it was really important to bring attention to this because there's quite a history behind how patients react once they're pregnant. So it's not all just about getting you pregnant. Sometimes it's about what happens once you're pregnant. And we wanted to make sure that we had everything we needed for you to be as educated as possible and as knowledgeable as possible about your journey. So I was on Instagram and I found someone in the UK who I think she must have been a doula or something along those lines. And she was recommending that people delay delivery of their pregnancy till after 42 weeks. Now, 42 weeks is unheard of in North America because we all know that it very significantly negatively alters your outcomes and increases your risks. And so we usually stop at 41 weeks. And in fact, there's data to show that you should actually be induced earlier. So I thought I would respond to this and ask the person if they were aware of the data, at which point they pointed me to a bunch of different websites and posts from other people, in particular midwifery group in the UK, where they said that this is safe and it's fine. And when I pointed to randomized controlled trial data, clearly demonstrating that it wasn't, they banned me from their site. So I thought, you know what, we should maybe make a point of this and create a little video on it. So this video is a quick fact or fiction on whether or not it is safer to be induced earlier than your due date, or is it okay to wait till later? So there are sort of 3 or 4 key trials that I want to quickly review with you. And the main question is it safer to be induced earlier, let's say 39 weeks, because that's usually the earliest that we tend to induce. And if you're being induced earlier, is it safer? Does it have better outcomes for you and for the baby? And does it have a good sort of appreciation of that event? Do moms like it better when they're induced, or do they like it more when it's natural? And so this is really important because we want you to have a really positive journey. We want it to be a good experience for you. And it's very important to a lot of women to be in control of their labor and delivery process. And I totally respect that and want the same thing. But at the same time, we also want to balance that with the need to have a safe and healthy outcome for you and for your baby. And in the past, there was a big push away from doing inductions because of the fact that it increased the risks of cesarean section. But the question is that actually true when you do head-to-head comparisons? And therefore, is it as safe or safer to deliver the babies a little bit earlier? And then the other part of it is, what happens if you wait? Are there risks to waiting? Are there risks of cesarean section? Are there risks of stillbirth? Is there risks of morbidity, mortality, injuries to the infants, and so on? And so, or to the moms. And so all of that needs to be looked at really carefully. So the first thing I want to look at is this study from Sweden, which was really important for these folks out in Europe, which had posted this, because this literally directly contravened what they were saying. So this study was called Induction of Labor at 41 weeks, which we wouldn't even wait till, versus expectant management and induction of labor at 42 weeks, which is what they were proposing, except they were saying you can go even beyond 42 weeks. So their primary outcome out of 2,760 women, 14 different hospitals in Sweden, and this trial was run from 2016 to 2018, was, were the infants going to be at a higher risk of stillbirth? So obviously this is the worst possible thing that could happen to anyone, especially if you're a fertility patient, because you've gone through all of this time and effort and grief and trauma to get to the point where you're going to have a baby. And then a stillbirth, which is a horror for anyone, is compounded with the background history of emotional trauma and sometimes physical trauma, and certainly financial trauma that can go with infertility as well. So the question was, is neonatal mortality, stillbirth, APGAR scores of less than 7 at 5 minutes, and acidosis, where the baby is at a much higher risk of having cerebral palsy or sort of mental dysfunction later, intracranial hemorrhages, convulsions, meconium aspiration, mechanical ventilation, all of these things were built into their analysis. So this was what I pointed out to them, and this is what got me stopped on their site, which was that in the group where they went ahead and induced, there were no stillbirths. And in the group where they did not induce and they waited, there were 6 stillbirths. So they actually stopped this trial early before it hit even its target endpoints, because there was such a huge difference in safety. They said, we cannot continue. It would be unethical to continue. And the Data Safety Monitoring Board actually stopped the study. There was no difference in the number of cesarean sections in this study. And therefore, they concluded that you should not be waiting until 42 weeks. You should actually be delivering once you're 41 weeks. So this is the first trial that kind of jumped to mind, because this is really important for everybody to understand. So it is not okay to wait up to 42 weeks. Once you hit 41 weeks, you should be induced. So there are some people still that say, oh, I want the natural approach. You're actually taking a huge increase in risk of having an adverse outcome, including stillbirth. So then they were saying, well, someone else responded and said, well, what do you think about, their experience? What about pain? And what about the trauma of having to go through the induction? So actually, from that same trial, they actually looked at this. So I want to highlight just this one part for you. And I'll just circle this in red because it's the conclusion here, right? So super easy. It says there were no differences in childbirth experience according to CEQ2 or overall childbirth experience assessed with a visual analog scale between women randomly assigned to induction of labor at 41 weeks or expectant management until 42 weeks. Overall, women rated their childbirth experience as high. So the idea that you're going to have a bad experience or a negative experience by being induced is simply not borne out by the idea that it's going to be a negative experience. The reality is it's actually going to be a good experience, and it's the same as it would be when you are being allowed to wait and go naturally. So these women that are being induced are not having a negative experience. They're perfectly happy with their experience. So there's no trauma, there's no significant difference in terms of your pain scale or anything like that. They looked at your own capacity, the perceived safety, the professional support. It all came back being exactly the same. So there's no harm, at least mentally, emotionally, from going through this. Probably the most important trial is this one, which is an American trial called the ARRIVE trial. So in the ARRIVE trial, they actually said, let's take a look and see in low-risk women who have never had a baby before, if it's safer to induce them at 39 weeks, or should we wait until 41 weeks? And so they randomized the groups and they said, let's see what happens. So this one I want to spend a few seconds on because I think it's really important to look at what happened here. So in this study, essentially what they did was they randomized multi-center study. They looked at women that were 38 to 38 weeks and 6 days. And then they decided to induce them at 39 weeks and 0 days to 40 days. So somewhere in that week. And they basically said that they wanted to look at this primary outcome, which was a composite of death and severe neonatal complications, like I just read from the other study. And the secondary thing was what happened to the cesarean section rate. Did it go up because you were being induced, or did it actually go down because you were being induced? So they ended up with 3,062 women assigned to labor induction and 3,044 that were assigned to expectant management. So this is a big study, over 6,000 people in it. So 4.3% of neonates in the induction group and 5.4% in the expectant management group had the primary outcome. Now, it just missed significance for demonstrating that the expectant group had a higher risk of these severe complications and stillbirth, because the confidence interval is on 1, and if it was literally a decimal place lower than that, it wouldn't. But that was the composite outcome. Interestingly, they found that the cesarean section rate, which you can see right here, was 18.6% in the group that was induced and 22.2% in the group that, was not induced. So I'll just highlight that for you guys so you can see it. And that is right there. So you can see it's 18.6% versus 22.2%. So in other words, you're going to have a lower cesarean section rate if you are induced rather than waiting for expectant management. What's not shown in the abstract, but is evident later into the article, is the fact that they actually showed that there was a higher rate of high blood pressure and preeclampsia in the moms that were in the expectant management group, and that was reduced in the group that was induced. So it's actually safer from the maternal perspective and from the fetal perspective, very likely to be induced. And there's actually no benefit to waiting, because all you're doing when you wait is actually end up with a higher risk of cesarean section. So it's not beneficial to wait. And I've actually been inducing our IVF patients for, probably 13 or 14 years when they got to 39 weeks. This data just further supports what we were already thinking and doing. The last part is right here, which is another study where they actually broke down the individual level data from that previous ARRIVE trial that I just showed you. So you can see here 6,096 women with outcome data, 5,007 met the inclusion criteria for the secondary data analysis. I've highlighted it in yellow here for you. In multivariable analysis, intended labor induction at 39 weeks was associated with a reduced perinatal composite outcome, so 4.1% versus 6% when they reanalyzed it in this study, and this is highly significant. They also showed that with an increase in BMI, you also had an increase in the perinatal outcome, so that was important as well. So this was super, super important, because this actually went one step further, showing that it's actually safer for the baby to be induced at 39 weeks rather than wait. So overall, the questions are, is it safer to have your baby at 39 weeks? Yes, it is safer for the baby. Is it safer for the mom to have the baby at 39 weeks? Yes, because you're reducing preeclampsia. Is it going to lower or increase your risk of cesarean section? It is going to lower your risk of cesarean section according to the largest trial. And then the only thing you're left with is it satisfying to moms? And the answer is there's no difference in satisfaction. So given the choice between risk mom and risk baby, or accept lower risks of a cesarean section and negative outcomes, why would anybody choose to wait? So I'm happy to hear your feedback. I'm happy to take criticism if you still feel strongly that you should wait, but the reality is the science doesn't support that. The science supports the fact that it is safer to be induced, safer for baby, safer for mom, and no difference in satisfaction rates. So whether you're seeing a doula or you're seeing a midwife, or you're going this on your own knowledge, or you're seeing an obstetrician, it doesn't matter. The reality is the science is very, very clear here in randomized controlled trials, demonstrating that the safety profile is much stronger for elective induction at 39 weeks than waiting till 41 or 42 or anything like that. So I hope you enjoyed that. The fertility factor fiction is a fact that induction of labor at 39 weeks is safer, reduces complications, and is beneficial for both mom and baby. We're going to take your questions live now, and next week we will have another exciting topic, hopefully. And congrats to Tarek off camera, who just finished fasting for Ramadan. So
That's what we do here. Getting induced at 39 weeks, 5.5 weeks to go. This is a statement, I guess.
oh, perfect. Good. Thank you for being induced. That is the right choice.
I should be getting my period in a few days to do fertility, but nervous about the blood collection. How much is needed? I couldn't get a Diva cup inserted and worried I won't collect enough.
You don't need too much. It's a fairly small sample because they're running PCR. So as long as you have, a few drops of blood in there or more, you should have more than enough. You don't need a ton.
Hello, Dr. Victory.
Hello.
I am 12 DPIUI
Okay.
and at 7 DPIUI, 11 DPIUI. I had extreme lower abdominal tightness like I had done a core workout, but I didn't.
Okay.
Any ideas as to what this could have been?
Could be a cyst rupturing or resolving. It can be your bowel, or it could be implantation related symptomatology. If ever you have pain that's persistent, just make sure you're being checked, because we never want to miss an ectopic pregnancy, although that early you would never notice it, but nevertheless, always be cautious. So pain in pregnancy can be okay, but it's never necessarily normal. So if you have pain, make sure you're being evaluated.
Do you prefer Clomid over letrozole? If so, why?
Well, no one should prefer Clomid over letrozole for PCOS, because there's an author by the name of Legro who back in, I want to say 2006, had a randomized controlled trial head-to-head for PCOS women, where they compared the outcomes, and letrozole was better. It was 27.5% versus 19.1% for Clomid. So that shifted the whole fertility world towards using letrozole instead of Clomid. If you're just trying to make people make more eggs, arguably Clomid's a little bit stronger for that, but there is no difference even for something like unexplained fertility in head-to-head trials between Clomid and letrozole as well. So they're kind of equivalent for most cases. Maybe there's a bit of a favoritism for Clomid if you're just trying to make more eggs. But if you have PCO, you should definitely be on letrozole, because it's crystal clear that it gives you a higher chance of success.
Is dual stim still effective if the 2 cycles are broken up?
Yeah, so actually what we've been doing a lot of is broken cycle duostim. We got to, find a good name for that, but split cycle duostim, I guess. Because when I go to get the eggs, I tend to retrieve some of the ones that could be kind of borderline and be included in a duostim cycle later. And so we actually split it up because we find we get more eggs for our patients by doing that, and it doesn't cost anything different. So for us, that seems to work very, very well, and is kind of our go-to approach to things in most cases. Not always, but in most cases, that's what we're doing. There's a study that's coming out soon, just popped up online in the advanced kind of articles section, I think of Human Reproduction or Fertility and Sterility, where they looked at the percentage chance that you would develop a good quality embryo based on the size of the follicle at the time of trigger. And anything above 12 to 15 millimeters actually had a chance. It's much better once you're into the 19 to 21 category. That's the highest rate. And certainly like 16, 17, 18, 19, 21 have the highest rates of forming good blastocysts. But if it was smaller, you had virtually no chance. So, or at least a very low chance. So we are still picking up some of those ones that are in the 12s, 13s, because we may still get embryos out of them. And as a result of that, we just split it and do a second cycle later, where we can actually pick up more eggs, and the embryo quality does seem to be better in my estimation. And that's what the studies have been suggesting as well.
Would you give an example of the type of IVF protocol you would use for a DOR patient age 39? AMH 0.2?
Well, arguably, if your AMH is 0.2, the first thing I would be talking to you about is if you want to use your own eggs, which is totally fine, I'd probably be focusing on the natural cycle IVF, where we actually just take the one egg you naturally make. If you have a decent antral follicle count where you are capable of making more, like 3 or 4 or 5, then based on the studies, there is no difference in any protocol other than that we know DHEA may increase your live birth rate. Human growth hormone can increase the number of mature follicles that you get. And then beyond that, whether you use testosterone priming or you want to try microdose flare or you want an antagonist cycle, those have all been shown to be the same. The only other thing which we recently reviewed on the show is that apparently letrozole does increase the chances of success as well. So we do keep our patients on letrozole also to try and see if we can kind of perk up the response. And that does seem to help a little bit. You won't see the estrogen rise as much, but we do see more eggs being developed, I think, and usually better quality embryos. So as a result of all that, it's certainly a reasonable approach to things to try those. But I actually encourage a lot of those patients where the AMH is very low to just do natural cycle IVF, because if I'm going to give you tons of medication, a lot of expense, a lot of shots, some discomfort, some side effects in terms of symptomatology, and you're only going to produce 2 eggs, I can do all of that for less and just do a second cycle a month apart. So it really depends on what your egg production capacity or potential is. If you can make 4 or 5, yes, of course, it makes sense to go on a protocol where you can make 4 or 5, because the dollar value of each embryo drops and you're getting a better value by doing it all at once. But if you're only going to produce 1 or 2 and you need a lot of medication to do so, I can get it for you cheaper just doing 2 natural cycles in a row. And actually, I do believe that the embryo quality from those natural cycles is often much better.
Howdy, Dr. V. Is there any link to a better FET outcome if the Lupron depot injection stops your period prior to the transfer? Any major issues if I still got my period after the injection as I gear up to thicken my lining?
So almost everybody will get a period after the 3.75 milligram Lupron injection. If you took it on cycle day 21, virtually everyone gets a period. So that's expected. We're not anticipating it'll stop you from having a period. It's too late in the process. It would be the rare case where that actually happens. So for most people, they will do just fine and have a period. As far as, is there a difference in outcome? I've never seen anything that looks at a comparison between period and no period. So I don't think that would make a difference. The one exception is if you have endometriosis, in which case you really should be suppressed and not having a period for 3 months prior to doing the embryo transfer. And that suppression has to be a combination of Lupron and letrozole.
Hi, Dr. V and T.
There you go.
I'm 35 and declined birth control prior to stims. But after 43 days and no period naturally, I was given 7 days of Provera 10 milligrams.
Sure.
Could this negatively impact my egg retrieval in any way?
Not at all. I mean, you don't even actually need it if you're just trying to retrieve eggs, because you can actually start ovarian stimulation at any point in the cycle. We learned that from our cancer patients, where we don't always have time to wait for a period. But if you're trying a natural, if you're trying a fresh embryo transfer, you need the period. If you're not trying a fresh embryo transfer, it really doesn't matter. So you can go ahead at any point in time, and the Provera will not negatively impact anything. It'll be just fine.
Hi, Dr. V and T.
V and T.
Is it atypical to have only 11/26 eggs survive to thaw?
Oh yeah, somebody asked us that this morning. I asked them back. Did she answer? I asked you back if that was eggs or embryos. I should have the answer on my phone.
She said eggs now. Only 11 out of 26 eggs survived the thaw.
Yeah, but I asked her if she meant eggs or only one what?
Only 1 day 6, 1 day 7. Realistic, I might have to do a new retrieval. Good AMH for age 36. Is it worth changing stim protocols?
Okay, so if you had 11 out of 26 eggs survive, eggs don't survive that well. So depending on what the quality was going into freezing and where you did it, it would make a big difference in terms of the outcome. If you had 11 out of 26 embryos survive the thaw, that's a lab problem for sure. I mean, I've never heard of anything even close to being that poor. So something is definitely not right when 11 out of 26 embryos survive a thaw, but I don't know why you would have thought 11 out of 26 embryos. So I'm assuming it was eggs. And even with eggs, that's a very low number. If you look at the research, usually around 70% will survive the thaw. So 11 out of 26 is really quite low. I mean, that's less than 50%. You're probably around the 40% mark there. I would definitely want to have somebody take a look at that and figure out what happened. Is it protocol based? I doubt it. It's probably more lab experience based. Tarek's shaking his head. He wants you to come see us.
I could have unfrozen those eggs.
Yeah, you could have unfrozen those eggs better.
Hi, Dr. Victory. Would you recommend 2-month Lupron Depot to prepare for third FET for someone who had 2 failed FETs with PGS tested embryos? 36 years old, never been pregnant, perfect lining. Continue. There's more. Clear sonal saline, no known issues. Emma, Alice, and ERA normal. Adding fragment due to DVT history. Interlipid 4. Starting acupuncture. Could Lupron Depot help to have a successful FET? Thanks.
So if you have endometriosis, Lupron plus letrozole has been shown to be beneficial for patients with unexplained failures. PRP may be helpful for you as well. We've started doing that here. I'm not a huge believer in Emma and Alice, but the Fertility testing is very valuable. So I would explore that for sure before going ahead. And I would actually seek a second opinion before you do anything, because oftentimes we figure out what's wrong and we fix it. I just got a message, which I was going to post, from a lovely couple who had been trying for 5 years and just did their IVF cycle with us and had their first positive beta ever. So we're really good at figuring out what's wrong, because I spend the time to figure out what's wrong before I let you do the treatment. I don't believe in putting people into treatment before I know what I can fix to help them. If I can't help you, just doing it again in a different center isn't necessarily going to be beneficial. I'm very proud of our team. I'm very proud of what we've achieved. I'm really proud of the amazing results we have. But I think a lot of what we get is not necessarily, a groundbreakingly different technique. It's us customizing your fertility care to you. And I think that makes a big difference. If you just take apples and compare them to apples as far as fertility techniques, it's not going to make that much of a difference in one center versus another. But if you're looking at how we treat people, we don't treat you as an apple to an apple. We treat you as an individual. So we don't lump people into categories. I take every single thing about you into consideration. And based on what I think is wrong and testing to support what I think is wrong, we would then go from there. If you've had 2 failed PGT tested embryos, I would spend a lot of time figuring out what's wrong before you do your next transfer, for sure. Because almost undoubtedly, you're going to find something wrong. 2 PGT tested embryos should yield an 84.1% chance of success. Moving up to 3 PGT tested embryos, you get up to 95.2. So yes, there is going to be an incremental increase with that final embryo. But if you look at it, it's actually only 11% more than you've already achieved. So that's not great. And as a result of that, we really want to make sure we're doing every single thing possible to ensure that you're getting the best possible outcome and a successful outcome for sure. Happy to talk to you. If you want to do a consult with us, you just have to email info@drvictory.com, ask for a consult. They will set one up for you. We don't even charge that much for a consult. And I spend a full hour with you on Zoom trying to figure it out.
Hey, Dr. B&T. Thanks for taking our questions.
Oh, no problem.
Any recommendations for women with Hashimoto's planning on IVF?
Yeah, see your endocrinologist or your RE and make sure your thyroid is completely stable before you do anything, because there is a decrease in success and an increase in miscarriage in patients with thyroid complications, especially Hashimoto's. So we want your levels very stable and we want your antibody levels to be negligible.
Is there a difference between medicated versus modified natural transfer? Is one better than the other?
That's a great question. I love that question. It's hotly debated in the literature. Every couple of weeks, there's a study that says natural is better, and then another study a couple of weeks later that says there's no difference. And then a few weeks later, one that says that the programmed cycle is better. So nobody knows for sure. At the moment, I don't think it makes a difference. I think it's much more how you manage this cycle. However, I will say that if you're doing a kind of garden variety embryo transfer cycle where they put you on a lot of estrogen, that probably is not as good as doing a natural cycle. Lower estrogen levels are probably beneficial for embryo transfers, and I think it's a big part of why we're so successful. So I would stick with making sure that you have low levels of estrogen as much as possible.
Do you find that there are any impacts in success of induction with a patient that is not dilated or cervix soft versus a patient dilated a bit with soft cervix?
So there are lots of studies on that. If your cervix is not ready, you need to be ripened, as we call it, for the cervix. And then there isn't really a big difference. But interestingly, in this particular study, the ARRIVE trial, they did whatever they had to for everybody, and they still got a lower cesarean section rate. Overall, when they look at these induction studies, including the ARRIVE trial, like over 70% of the women were able to deliver vaginally. So it's a very reasonable approach to things. That is a fantastic question, though. I applaud you for asking that.
Do you suggest PGS genetic testing?
Well, that's a great question. So yes and no. So first, let me tell you that there is going to be a shift coming because they just day before yesterday published a new article that is in press saying that it should no longer be used, that there are too many mistakes and that it has not been proven to be valuable in randomized controlled trials when the trials are analyzed properly. And therefore, as a result, it should be research cases only or women that are definitely significantly in the higher ranges of reproductive age. So what do we do right now? I have 3 categories of patients that we use PGT-A for. So these are people just trying to figure out if their embryos are chromosomally normal. We are not talking about people looking for cystic fibrosis or beta thalassemia or something like that. That's different. That's PGT-M. But for PGT-A, where we're just testing for 46 chromosomes in the cells, there's 3 groups for us. So group number 1 would be the obvious one, which is if your age is over 38, there is a reasonable amount of evidence that it will make things at least more efficient, if not actually make a difference. And there's a cost-benefit ratio that starts to creep in at that point where putting in abnormal embryos is not worth it. So we should really be focusing on putting in normal ones. Group 2 is the group that has previously failed an IVF cycle and they're young. So if you failed a previous IVF cycle and you're less than 38 years of age, I need to know why. And without knowing if you're producing genetically normal embryos, it's hard to say if we know the reason why. So that group I would definitely recommend as well. The third group is the group that is under the age of 38 but has diminished ovarian reserve or DOR. So for those patients, we know, and we've reviewed it on the show here probably 3 months ago or so, 3.5 months ago, that patients that have lower AMH, higher FSH, lower antral follicle counts actually have a higher number of genetically abnormal embryos. So in that group, I do think it's worth it because, again, you want to know if the embryos you're producing are normal or not normal. So yes, those are the 3 groups we consider doing it for. But there will be a shift coming to suggest that we should stop doing PGT-A for people because there's no science to back up using it in most groups, and certainly not all the ones that they use it for. We get people asking us all the time if they should use it in the donor cases. And the answer is very clearly no, because in a young donor, it doesn't even make mathematical sense, let alone any scientific sense. So we do not recommend it for many of our patients. For those that we do, we're picking it based on very specific select criteria and for good scientifically valid reasons.
MFI. Should my husband continue taking Mucinex for semen hyperviscosity?
Mucinex?
Yeah, even if it's been being washed for IUI?
No, you do not need to worry if it's being washed because we eliminate all of the viscosity when we put it through a wash. So that's not going to help in any way.
Lupron suppression.
Yeah.
When you finally do get your period,
Yeah.
will hormones, specifically estrogen, go back to levels one has prior to Lupron?
In theory, they should. So the question is, if you've taken Lupron for suppression like 3 months, will your estrogen level return to the pre-suppression levels? It should in theory, unless something has significantly changed in that 3 months for you, you should go right back to where you were before.
Could higher levels of TSH above 3.5 cause implantation failure?
If you believe the Endocrine Society, yes. So they recommend that you have it less than 2.5. I saw that from someone the other day, actually. So yeah, if you're at 3.5, you want to reduce it down to less than 2.5. I don't know that there's any very clear scientific evidence that shows that it will drastically reduce your risks. So we allow some people to stay a little bit higher. And we certainly don't panic if they're not ideal at the time of the embryo transfer. But in an ideal situation, you should have everyone less than 2.5 for their TSH, as long as their T4 is normal and their antibody levels are low.
How long after transfer is it safe to begin exercise again? Specifically yoga, warm and hot classes, cardio, and light weights?
No hot yoga, so that's a no-no. You can start exercising probably within a day or two, but nothing intense. The weightlifting should be reasonable. Your heart rate should stay under 120.
Can someone monitor at a local clinic but come to you for dual stim?
Oh yeah, absolutely. We do that all the time. I had a couple in the Virgin Islands come to us for duostim and have the best cycle they'd ever had. So the best 2 cycles they've ever had. So yeah, you can monitor everywhere and come to us. That's not a problem at all. We are very international, which is cute because we're in this small community of Windsor, but we are extremely international. We have patients coming from Spain, from Australia, from the UK. We've got patients coming from all over. So yeah, we have a lot of people coming to visit, and you know, like I said, the Virgin Islands, they came here specifically for duostim. And they did amazingly well with it. So yeah, we've got people coming. If you want to monitor somewhere else and show up here for your retrieval and your embryo creation and then subsequently an embryo transfer, we do that all the time.
What supplements do you recommend before a transfer to help with lining?
We really got to create that video. You know what, that has to be, we need like a video that's just, here are the supplements you should take, and we just like put them up there, right? Okay, so melatonin, vitamin D, your prenatal, the fish oils, those are the most important ones. We do use aspirin. That's helpful as well. And then depending on what conditions you have, PCO, endo, different things, there may be additional supplements we would use.
Hey, Dr. V, DM'd you on Sunday night for my FET number 2 on Monday, yesterday.
Okay.
You replied, baby dust.
Oh, yeah.
I loved the sound of it, even though I wasn't sure of the meaning. So I looked it up, and you are awesome.
I remember that. So congrats on your embryo transfer. And yeah, that's like a fairly common internet phrase, which is, you know, wishing you baby dust or sprinkling baby dust. So that's what that was coming from.
Starting Lovenox shots, morning versus evenings. I do progesterone oil shots in the AM in the bum. Would love to save Lovenox for PM in the belly if okay to do so. If not, oh well.
Oh yeah, it doesn't make a difference at all. As long as you get it, it doesn't matter if it's morning or night.
Dr. V, this is Victoria.
Hi, Victoria. Okay.
I had an appointment with you. Where is it? I lost it. Hold on. I had an appointment with you this week and forgot to ask if I should proceed with endoscope surgery. Unexplained DQA match. Need second round of antibiotics for urea bacteria, if you recall.
Yep. Yes, I think it's very reasonable to consider endoscopy. But this is a general statement. I'm not saying it specifically to you because we can't do that online. But in general, I think for patients that have had failures or are at risk of endo or a reason for why they can't conceive, I am much more proactive about the surgery than pretty much any other fertility specialist, because most fertility specialists see it as a loss of income or a delay in getting the patients enrolled in fertility treatments. I don't care about that. I'm just interested in making sure you get the best treatment possible. And that actually can include surgery. So that's an important thing for you to look at. Yep.
Had a gastric bypass about 11 years ago now.
Okay.
A little over 18 weeks pregnant. Do we do the glucose test to check for diabetes, or would the test not be reliable because getting dumping syndrome from sugar body doesn't handle sugar well? So I was worried about drinking the sugary drink.
You can't drink the sugary drink. You should just have a fasting hemoglobin A1C and fasting sugar. Do not drink the sugary drink. You will get dumping syndrome and it'll be wretched. So that's not good. Definitely don't take the sugary drink. Just do the fasting sugar and hemoglobin A1C.
What are the risks of doing stims and egg retrieval with a TSH of 0.2? I have Hashimoto's, and my doctor increased the dose to be between 0.5 and 2.5, but it brought down too low, and the egg retrieval is soon.
It can impact egg quality. Certainly getting pregnant at that level, if your TSH is too high, is going to be a risk for miscarriage. So make sure your thyroid is as stable as possible. And if you need to adjust the dose even now while you're in stim, you should.
Hello. With that study you just read to us, I missed some of it. Is that your standard of practice inducing at 39 weeks for all your IVF patients? So when I do my transfer with you, I get pregnant, should I expect induction?
Well, I offer it to everybody and I explain the benefits as we did here. We certainly don't force anybody into it, but we offer it to we actually offer it to all of our patients, whether they're fertility patients or not. I have the discussion at 38 weeks. Would you like to be induced or would you like to wait? Here are the risks, here are the benefits. What would you like to do? And then if the patient says, yes, I'd like to be induced, we induce. And if they say, I want to wait natural, we say, great, wait for natural. I mean, I'm all about your autonomy. You should be in control of your health and your body. And so I will explain the risks and benefits of all the different choices, whether it's fertility related or pregnancy related. And then I let you choose what you want to do. I am not jumping into anybody's brain to tell them what the right or wrong thing is for them. That's your decision. But my job is to educate you. So I know my information, which is why we did the presentation tonight, so everybody's aware. And then if you still, having heard that, want to, take your own kind of values and thought processes and emotions and concerns and desires for what you want as a healthy pregnancy outcome into consideration, then you should have the right to do so. And we totally respect that.
Hey, Dr. V&T.
V&T.
I love your sessions.
Oh, good.
Quick question. I am one of your new patients and completed all my testing and have an initial appointment with you in a few days.
Oh, awesome.
Just want to check, if we decide to proceed with IVF, can we start the process immediately next cycle or have to prepare my body for a few before starting protocol?
It depends on what's wrong, especially if it's male factor, because male factor can take a few months to improve. But if it's something simple, like your tubes are blocked, yeah, you can try it with your next cycle. If it's more complicated and we need to alter vitamin levels or health habits or body mass index, then that's a different story altogether.
Hi, Dr. Victory. I had a rough recovery from my retrieval, but got incredible results. 36 follicles retrieved and finished with 22 embryos. What am I expect when I get my FET? I am scheduled to get my depot Lupron shot tomorrow to prep for my transfer. Any side effects I could possibly experience? Just want to prepare for the worst as my retrieval was tough on me.
Well, I'm sorry your retrieval was tough on you. Congrats on the spectacular blastocyst formation. That's pretty amazing. So in terms of Lupron side effects, usually with the 1 month shot, which is what we use for our prep, you shouldn't have any side effects at all because we're going to roll you onto letrozole and you're going to have some estrogen. And the only sort of negative side effects from Lupron that most people experience are the ones caused by having a low estrogen level, and we're going to counteract that by giving you some estrogen. So most women on the Lupron really don't complain about it.
Regarding the eggs or embryos?
Yeah.
Eggs.
So 11 out of 26 eggs. Yeah. Well, I can tell you that's not us. So I don't know where you did it. Maybe DM me again and chat with me because that's not normal. For sure, that's not normal. I'm not, I mean, I think anyone that watches our show knows I'm not a huge fan of frozen eggs. I'm not a big believer in it. I will do it where it's appropriate, but we don't do it a lot. And we certainly don't use the frozen donor eggs because we're not quite comfortable with that in terms of the same success that we get with fresh. Having said that, the few instances where we have done it, our lab director is outstanding and we've actually had spectacular results every time. So, I mean, I am on board with doing it where necessary, but something has gone terribly wrong if you're only getting 11 out of 26. That just doesn't make sense at all. So, you know, that's the kind of blastocyst rate we would expect, let alone egg survival. So yeah, I would definitely get in touch with us and let's talk about what happened and where you did it and what went wrong.
What is the percentage of success for a woman over 40 using donor eggs?
Well, it depends on where you're going and what factors are involved in you. If you're a healthy woman, the sperm's not bad. You know, your body mass index is normal. You don't have any bad habits. I will tell you that the success rate's very close to 100% with us. So we rarely will fail. So yeah, it's outstanding.
Can someone after ectopic pregnancy?
That's very good, man. Sometimes you reread. You caught yourself this time.
I only reread when they're double dipping.
When they're double dipping on the platforms.
Yeah,
Yes,
right.
I know.
After ectopic pregnancy and takeoff methotrexate, how long before the next FST?
FST?
That's what I got.
FST.
A lot of cool words. I got takeoff.
I don't know what FST stands for. Sorry, but methotrexate, you need about 3 months for that stuff to wear out of your system. So it takes a little while if you had a methotrexate shot.
When can we transfer after stopping breastfeeding?
Minimum 6 weeks later, although if testing is required, then you've got to account for a month of testing in there too. So we normally make our patients wait at least 6 weeks because you need your prolactin levels to come down. Otherwise, they counteract the ability of the embryo to implant.
2 failed embryo transfers, failed to implant.
Sorry.
One was 2 euploid embryos. The other was 1 untested 6 AA embryo.
Wow.
What could be the reason for that? Additional tests that can be done?
It could be a whole bunch of things. So when we talk to patients about the potential sources of embryo transfer failure, we talk about the passenger, the passage, and the destination. So the passenger is the embryo. So number one would be, even if it was euploid, was there something wrong with the embryo in terms of energy efficiency, quality, you know, what grade was the blastocyst in terms of, is it a B quality, an A quality, a C quality? What about the trophectoderm? Was that ABC? Because that makes a difference. Number two is the passage. So did they do a good embryo transfer? Are you retroverted, retroflexed, where we only do transvaginal ultrasound guided embryo transfers because you can't see unless you do that. And then number three is the destination, which is you. So the you part is huge. Immune system, infections in your uterus, abnormal microbiome in the vagina and the uterus, weight, habits like smoking, drinking, drug use, including marijuana, vitamin intake, immunological issues, thrombophilias. There's all sorts of things we look at to make sure that everything is perfect. So can you do testing? Yes. We do a lot of fertility testing for infections, for immunological problems, but you can do it anywhere. We just use that company, but I'm not supporting that company. You can use any company you want. You can do thrombophilia screening. You can do surgery to look for endometriosis, which could be a possibility as well. You can do genetic testing for you and your partner. You can do swabs to look for bacteria. You can do thyroid testing, hormone testing, vitamin testing. So there's a lot of stuff that can be done to explore and figure out what's wrong.
Can I recheck my fertility 26 days into TX versus after the full 30 days based on when I expect my next day one?
Yeah, you could. I mean, it's probably going to be just as good as waiting an extra 5 days. By that time, it should be all killed off. So yes, I wouldn't tell you need to wait.
Hi, Dr. Vinti. How long does it take for the consultation after all the initial testing is completed?
If you contact us once your testing's done, usually we get you back in within about a month to 2 months maximum. So we normally get people in pretty quickly after their testing's done.
What protocol do you recommend for transfer, medicated or natural?
I don't know if that's the same person that asked it before. As I was saying earlier in the show, it's basically controversial. We use a modified natural, or I guess a modified medicated, depending on which way you want to look at it. But I do that based on the science because there's lots of evidence that certain things help. So we use the stuff that helps, like letrozole, for example. Different person.
For the record, yeah.
Cool.
For someone with endometriosis and adenomyosis, would you recommend 2 or 3 months of Lupron? I'm one of those with 2 failed PGT transfers. Yes,
100%. So 3 months of Lupron and letrozole, and actually, in your case, we would say surgery before you do another transfer. That's going to make a big difference, depending on how severe the endo is, but it can make a really big difference. So for us, we would not even try the transfer until we've operated and suppressed you both, because I want to give you your best chance possible, and that's going to be your best chance possible.
Why are they recommending baby ASA for patients with recurrent miscarriage?
Well, we have a video on that. So it's one of the more popular ones on YouTube. Can you find that one? Aspirin and something or other. Yeah, so we have a YouTube video on the benefits of aspirin. Aspirin improves blood flow, reduces inflammation. I'm not going to tell you that on its own, it's going to prevent a recurrent miscarriage, but it can certainly contribute in addition to other steps that we take to minimize your chances of a recurrent miscarriage.
Which fertility test would you recommend for one to get if they had 2 failed embryo transfers, no implantation?
So we tell them that we want the Victory combo because I made them create a combo just for us, which is the immune testing and the full microbiome for vaginal and uterine. So they bundle it for our patients at a lower price because I yelled at them. So we get that for the patients that want it. Now you can do it separately if you don't want to pay the full amount. But for me, if I'm dealing with failures, I want to know about the infections and I want to know about the immunological issues.
Thoughts on back-to-back retrievals for follicular cycles?
There's nothing wrong with it. It's essentially a modified version of duostim. So when you have a modified duostim where you're just spreading it into the next cycle, you're still getting some of that advantage from the stimulation of the previous cycle. So yeah, I mean, I think that that's completely a reasonable thing to do, and we have done that before. I guess I would ask, if you're going to do that, why wouldn't you just do the duostim? Because that luteal phase is supposedly better. And for all those of you who are watching, my beloved son Nassim, who I spoke to earlier in the day and said, I cannot talk to you between the hours of 8 and 9, just called. So Nassim, if you're watching the show, it's still between 8 and 9. So yeah.
What supplement should be continued after a positive beta?
Don't change anything after a positive beta. Literally don't change anything. Whatever you're on, stay on. The human body and pregnancies do not like disruption. They like homeostasis, which means everything's just in a nice, calm, even balance. So don't be going on and off of stuff, because that's a great way to cause problems in the pregnancy. Just stay on everything, follow up with either your OB or your RE, and they will tell you what to go on and off of and when.
You mentioned melatonin for necessary vitamins. Is it needed if sleep is not a problem?
Well, even if your sleep is not a problem, and we just reviewed sleep, was that last week or the week before? The week before, right? Yeah, it was the week before. 2 weeks ago, we reviewed sleep. So even if your sleep is not a problem, melatonin increases your chances of success. And that's been shown in several trials. So yes, you should be on melatonin.
Does high estrogen mean poor egg quality?
It can. If your estrogen is high at the start of the cycle, it often means that the egg quality will be compromised, yes.
When working with a patient for outside monitoring, how would you ensure the facility they are using are providing the proper information about the follicles? Also, is duostim similar to an LPS cycle?
Duostim is an LPS cycle for the second half. So it's a follicular phase stim and then a luteal phase stim, which is LPS. How do we ensure? We talk to the center. If it's a fertility center, you know they're doing the right thing usually. If it's not a fertility center, we make sure that they're following our protocol for the testing. It's mostly just the ultrasound measuring. So it's a 90-degree crosshatch measurement of the follicle.
Thank you so much, Dr. Victory, for answering my Lupron Depot before FET question. I already sent a referral at your clinic last week.
Oh, awesome.
So Ashley can schedule me for an early appointment.
We will do our best. It's a busy place, so we try as hard as we can.
Sorry, regarding Hashimoto's.
Yeah.
How do you get your thyroid antibodies down? TSH is under 2.5. Do you recommend IL therapy and steroids to use with transfer?
If your antibodies are really high, we'll consider steroids. We do supplements like selenium and inositol. And then you want to make sure your thyroid level, your TSH level is driven down as far as is acceptable without making you hyperthyroid, in order to also help bring down the antibody levels if they're really high. But it's delicate because you don't want to flip into being hyperthyroid either.
You mentioned that sperm DNA fragmentation is improved by ejaculating, then doing it again shortly after. Should a husband ejaculate before giving his IVF sample? Thank you so much.
Yeah, so if he has high sperm DNA fragmentation, there's a study that shows that a second ejaculate sample 3 hours after the first significantly reduces the DNA fragmentation. So we've built that into our protocol. So we ask them to give us a first sample and then a second sample, and we tend to use the second sample.
Dr. V.
That's me.
Where is my period?
Wait.
I just turned 50 and need a D and C hysteroscopy scar tissue before FET. I've taken 5 days of Provera. A week later, no period. Was told to do 150 milligrams IM of PIO. Where is Onflow?
Well, if you have scarring, Onflow is not coming because your endometrium is damaged. Also, if you're 50, we need to consider the potential that you're not producing enough estrogen to create a period. So I didn't take your period, so I don't know where it is, but I can tell you that I would be able to figure it out if we chatted for probably all of 5 minutes And then I got your results from an ultrasound and some lab tests. So there's absolutely never a reason why you would need to take PIO to get your period started. You need to know how badly damaged the lining of your uterus is. If it's really badly damaged, which you can figure out from a saline infusion sonohysterogram, on-flow isn't coming because the lining is damaged. If it's not that badly damaged and there are pockets of endometrium that can get out, then you need to see if your estrogen level is low and your ovaries have just kind of gone quiet just because of age. In which case, you don't need PIO, you actually need the birth control pill because you need estrogen, or you can take estrogen and then sequentially progesterone because you need the estrogen to build up the lining and then take the progesterone to get rid of it. I would, however, ask why they're doing that, because in order to do a hysteroscopy for scarring, we would actually want you on lots of estrogen and no progesterone, so that when you make the cuts, the estrogen is there to it's called epithelialize the lining and make it covered with all of the endometrial cells. The only way to do that is like feed it tons of estrogen. If you give it progesterone, you're actually doing the opposite of that. So don't do that. That doesn't make sense. 9 o'clock.
9 o'clock. Yep, 9 o'clock.
One more?
Sure.
Is there like a lot?
Yeah. There's enough for sure.
Tarek's terminal question.
Okay.
Pick a good one.
Pulling it from. Oh, I always enjoy one of these questions. Okay. A reproductive endocrinologist said that it was controversial to put an IVF patient on thyroid medication to lower the TSH. Why is it controversial? Do not all the fertility doctors agree about it?
It is not controversial. It's not controversial at all. It's Endocrine Society guidelines. ASRM recommends it. I don't know if CFAS does because I haven't looked at theirs, but anybody that says that it's controversial doesn't know what they're talking about. Sorry. Yeah, it's not controversial. It's very clear. There's a whole huge thyroid guideline from the Endocrine Society readily available to anyone. ASRM guidelines are available. There's no question that you should be managing the thyroid before an IVF cycle. Done? Even Tarek knew that one. Okay, guys. So for those of you who are Muslim, happy Ramadan and upcoming Eid. I hope it's a very spiritual and fulfilling Ramadan for you, and especially to my good friend off screen here, Tarek, and his family. And then for those of you who are going to be watching again next week, let me know if you have a special topic you want to learn about, because I'll be happy to discuss that. And we'll be back again next week, Tuesday next week with another exciting show. Thank you for joining us. Don't forget to follow, like, and comment.